Hemoglobin represents the total amount of this oxygen-carrying protein in the blood. Like hematocrit, it indirectly reflects red blood cell count. Hemoglobin is essential not only for delivering oxygen to tissues, but also for transporting carbon dioxide back to the lungs for exhalation. In addition, hemoglobin acts as a buffer, helping to maintain acid-base balance in the body. Because of these multiple roles, small changes in hemoglobin levels can have wide-reaching physiologic consequences. Normal hemoglobin values also vary by sex, age, and physiologic state. For adults assigned male at birth, the range is 14 to 18, versus female assigned at birth is slightly lower at 12 to 16. This is grams per deciliter. Pregnant individuals, we accept levels above 18 or above 11, excuse me. And in our elderly individuals, we can expect to see a slight decrease from normal. Pediatric reference ranges vary. They're typically lower, ranging from about 9.5 to 15.5, depending on age, with newborns again having the highest level up to 24 grams per deciliter to meet the oxygen demands outside of the womb. Critical thresholds for hemoglobin are important to recognize. A level below 7 grams per deciliter is dangerously low and often requires transfusion as the blood cannot adequately supply oxygen to tissues. On the other hand, hemoglobin greater than 21 grams per deciliter is critically high. This degree of concentration makes the blood viscous, raises clotting risk, and often reflects underlying bone marrow disorders like polycythemia vera or severe dehydration. Both extremes require urgent clinical action. Just like hematocrit, hemoglobin is part of the standard CBC, so it's ordered routinely. It is especially a valuable tool to look through different types of anemia, bleeding, or chronic disease processes. It can be tracked serially in patients with ongoing blood loss, like GI bleeding or post-op hemorrhage, to monitor stability of oxygen carrying capacity. And because it correlates so directly with tissue oxygenation, hemoglobin is often one of the most closely monitored lab values in acutely ill patients. The collection is the same as for hematocrit, a lavender top tube with EDTA and no fasting required. There are several variables that can affect hemoglobin. Pregnancy lowers hemoglobin because of the dilutional effect of increased plasma volume. There's also a natural diurnal variation as hemoglobin levels are highest in the morning and lowest in the evening. Lifestyle factors matter too. Heavy smoking raises hemoglobin due to chronic low oxygen levels, and living in higher altitudes similarly increases hemoglobin as a compensatory mechanism. Certain medications can either increase or decrease the levels, and therefore recognizing these influences can help us interpret results more accurately. Causes of increased hemoglobin will parallel the causes of elevated hematocrit. Erythrocytosis from chronic illness or physiologic adaptation, congenital heart disease and chronic lung diseases like COPD causing chronic hypoxia, stimulating more RBC production. Polycythemia vera, a bone marrow disorder, leads to uncontrolled hemoglobin production. Severe dehydration, as with diarrhea or burns, concentrates the blood, raising hemoglobin even though the RBC number is unchanged, and all of these represent important clinical context. When hemoglobin is decreased, it often mirrors hematocrit changes as well. The classic cause is anemia. Hemoglobinopathies such as sickle cell disease compromise hemoglobin structure and function, reducing overall levels. Cirrhosis lowers hemoglobin through chronic fluid overload and impaired production. Hemolytic anemia is going to destroy red cells prematurely, while acute hemorrhage gradually decreases hemoglobin as plasma volume equilibrates. Each condition has unique mechanisms but results in the same outcome, impaired oxygen delivery. Dietary and systemic conditions also lower hemoglobin, such as iron deficiency, B12 or folate deficiencies, by reducing the size and or number of red blood cells. Mechanical destruction occurs in patients with prosthetic valves where blood turbulence shortens red blood cell lifespan. Kidney disease decreases erythropoietin production, reducing red cell synthesis, and pregnancy dilution lowers hemoglobin, and splenomegaly can also contribute, as an enlarged spleen removes red cells more aggressively. These are all important considerations. Lastly, chronic disease and bone marrow dysfunction are also key contributors. Rheumatologic conditions like lupus or rheumatoid arthritis suppress red cell production. Bone marrow failure, whether due to aplastic anemia, toxins, or medication side effects, results in fewer circulating cells. And hematologic cancers such as leukemia, lymphoma, multiple myeloma, or Hodgkin's disease crowd out normal marrow function, decreasing hemoglobin. Identifying these causes requires integrating lab findings with the overall clinical picture. And here's a comparison slide looking at hemoglobin and hematocrit.